Next, we're going to talk about seizures. Seizures may result from metabolic disorders, acute alcohol withdrawal, electrolyte disturbances, heart disease, high fever, stroke, and substance abuse. Seizures can be created by metabolic imbalances, neurotoxins, and heavy metals in the body. Metabolic imbalances, most specifically imbalance to sodium, calcium, or magnesium levels, may cause seizures. Certain medical conditions which may cause a metabolic imbalance include kidney failure with uremia, urea in the blood, hypoglycemia, hyperglycemia, hypoxia, liver congestion, and/or failure. Seizures are generally described in two major groups: primary generalized seizures and partial seizures. The difference between these two types is how and where they begin. Partial seizures begin with an electrical discharge in one limited area of the brain. Many different things can cause partial seizure. For example, head injury, brain infection, stroke, tumor, or changes in a way an area of the brain was formed before birth, called cortical dysplasias. Many times no known cause is found, but genetic factors may be important in some partial seizures. Partial seizures can be broken down further depending on whether a person's awareness or consciousness, the ability to respond and remember, is affected. Primary generalized seizures begin with a widespread electrical discharge that involves both sides of the brain at once. Simple partial seizures are usually divided into categories depending on the type of symptoms the person experiences. Motor seizures. These cause a change in muscle activity. For example, a person may have abnormal movements such as jerking of the finger or stiffening of a part of the body. The movements may spread, either staying on one side of the body or extending to both sides. Other examples are weaknesses, which can affect speech and coordinated actions such as laughter and automatic hand movements. Sensory seizures. These cause changes in any one of the senses. People with sensory seizures may smell or taste things that aren't there. They'll hear clicking, ringing, or a person's voice when there is no actual sound, or feel a sensation of pins and needles or numbness. The seizures may even be painful for some patients. They may feel as if they are floating or spinning in space. They may have visual hallucination, seeing things that are not there, a spot of light, or a scene with people. They may also experience illusions, distortions of true sensations. For instance, they may believe that a parked car is moving farther away or that a person's voice is muffled when it's actually clear. Complex partial seizure usually start in a small area of the temporal lobe or frontal lobe of the brain. They quickly involve other areas of the brain that affect alertness and awareness. So even though the person's eyes are open and they may make movements that seem to have a purpose, in reality, it's not. If the symptoms are subtle, others may think the person is just daydreaming. Some people can have seizures of this kind without realizing anything has happened, and the seizure can wipe out memories of events just before or after it. An absence seizure causes a short period of blanking out or staring into space. Like other kinds of seizures, they are caused by abnormal activity in a person's brain. You may also hear this called petit mal, although that's not the name that is common anymore. There are two types of absence seizures. Simple absence seizures. A person usually stares into space for less than 10 seconds. Because they happen so quickly, it's very easy not to notice simple absence seizures or to confuse them with daydreaming or not paying attention. During a complex absence seizure, a patient will make some kind of movement in addition to staring into space. Movements may include blinking, chewing, or hand gestures. A complex absence seizure can last up to 20 seconds. And an absence seizure can also happen with other kinds of seizures. Myoclonic seizures are brief shock-like jerks of a muscle or a group of muscles. Myo means muscle, and clonus means rapidly alternating contraction and relaxation, jerking or twitching of a muscle. Usually they don't last more than a second or two. They can be just one, but sometimes many will occur within a short time. Some people without epilepsy can experience myoclonus in hiccups or in a sudden jerk that may wake you up as if you're falling asleep, and those things are normal. In epilepsy, Myoclonic seizures usually cause abnormal movements on both sides of the body at the same time. Generalized tonic-clonic seizure. As implied by the name, this combines the characteristics of tonic seizures and clonic seizures. The tonic phase comes first. All of the muscles stiffen. Air is being forced past the vocal cords, which causes a cry or groan, and the person loses consciousness and falls to the floor. The tongue or cheek may be bitten, so bloody saliva may come from the mouth. The person may turn a bit blue in the face. After the tonic phase comes the clonic phase. The arms and usually the legs begin to jerk rapidly and rhythmically, bending and relaxing at the elbows, hips, and knees. After a few minutes, the jerking slows and stops. Bladder or bowel control sometimes is lost as the body relaxes. Consciousness returns slowly, and the person may be drowsy, confused, agitated, or depressed. These seizures generally last 1 to 3 minutes. A tonic-clonic seizure that lasts longer than 5 minutes needs medical help. A seizure that lasts more than 10 minutes or 3 seizures without a normal period in between indicates a dangerous condition as status epilepticus, and this requires emergency treatment. In a tonic seizure, the tone is greatly increased and the body, arms, or legs make sudden stiffening movements, and consciousness is usually preserved. And a tonic seizure most often occurs during sleep and usually involves all or most of the brain, affecting both sides of the body. If the person is standing when the seizure starts, usually they will fall, and these seizures usually last less than 20 seconds. An atonic seizure is without tone, so in an atonic seizure, muscles suddenly lose strength. The eyelids may droop, the head may nod, and the person may drop things and often fall to the ground. These seizures are also called drop attacks or drop seizures. The person usually remains conscious, and these seizures typically last less than 15 seconds. They often start in childhood, yet last into adulthood. Many people with atonic seizures are injured when they fall, so they may choose to use protection such as a helmet. Another name for this type of seizure is akinetic, which means without movement. The ABCs of seizure. It is a medical emergency. Prolonged seizures lasting more than 5 minutes or repeated seizures over a course of 30 minutes. Establish the airway. Check the blood gases. The patient may need IV push lorazepam, diazepam, or rectal diazepam. Can begin with a loading dose of IV phenytoin. A seizure is considered an emergency when it lasts a long time or when seizures occur close together and the person doesn't recover between seizures. Nursing assessment. During the seizure, remain with the patient. Observe for, record, and report type, duration, and characteristic of seizure activity and any post-seizure response. This should include, as appropriate, a precipitating event, aura, initial location and progression, automatisms, type and duration of movement, changes in level of consciousness, eye movement such as deviation or nystagmus, pupil size and reaction, bowel and bladder incontinence, head deviation, tongue deviation, or teeth clenching. Prevent or break the fall and ease patient to the floor if seizures occur while the patient is out of bed. Keep patient in bed if seizures occur while there and lower head of bed to a flat position. If the patient's jaws are clenched, do not force an object between the teeth, because this will break teeth or lacerate oral mucosal membranes. If able to do so safely and without damage to oral tissue, insert an airway. Tongue depressors should not be used because they may splinter. A rolled washcloth might be an alternative. Protect the patient's head from injury during seizure activity. A towel folded flat or hands may be used to cushion the head from striking the ground. Be sure head position does not occlude the airway. Remove environmental objects, chairs that the patient may strike. Pad floors to protect the patient's arms and legs. Remove patient's glasses. Do not restrain the patient, but rather guide patient movements gently to prevent injury. Remember that in NCLEX land, you do not leave the patient's side. Roll the patient to a side-lying position to promote drainage of secretions and maintain a patent airway. Use the head tilt chin lift maneuver. Provide O2 and suction as needed. Loosen tight clothing, collar, or belt, and maintain a patient's privacy. Clear all non-essential people from the room and administer anti-seizure medications as prescribed. In the postictal state, provide a quiet, calm environment because sounds and stimuli can be confusing to an awakening patient. Speak slowly and pause between sentences. Repeating may be necessary. Use room light that is behind, not directly above a patient to prevent additional seizures and for patient comfort. Do not offer food or drink until patient is fully awake. Check the patient's tongue for lacerations and body for injuries. Monitor urine for red or cola color, which may signal rhabdomyolysis or myoglobinuria from muscle damage. Monitor for weakness or paralysis, dysphagia, or visual disturbances. If patient vomited during the seizure, notify the healthcare provider of increased potential for aspiration. Check finger stick blood glucose and obtain serum lab tests as prescribed. Check neurostatus and vital signs and ask the patient if an aura preceded the seizure activity. Record this information in postictal characteristics. Dilantin is given no more than 50 milligrams per ml per minute and can be given IV push, but be careful, the patient may get hypotensive. Once seizures are controlled, the drug should be continued without interruption until patients have been seizure-free for at least 2 years. At that time, stopping the drug may be considered. Most of these drugs can be tapered by 10% every 2 weeks. Relapse is more likely in patients who have had a seizure disorder since childhood, need more than one drug to be seizure-free, previous seizures while taking an anticonvulsant, partial or myoclonic seizures, underlying static encephalopathy, and abnormal EEG results within the last year. Of patients who relapse, about 60% do so within 1 year and 80% within 2 years. Patients who have had a relapse when they are not taking anticonvulsants should be treated indefinitely. Epilepsy is not a one-time event. The seizures can occur at any moment and without warning. An epileptic seizure occurs when the brain is experiencing electrical difficulty, and this is triggered by certain cells and neurons sending out the wrong signals. There is a large difference between a one-time seizure and epilepsy. A seizure is not necessarily epilepsy. A head injury can trigger a one-time seizure. For some patients, epilepsy carries a stigma that may cause them to alter plans regarding their future educational, employment, or social opportunities. It's important issues to address and include when educating patients about managing epilepsy are wearing a helmet if risk for head injury, general health habits like diet and exercise, assist to identify events or situations precipitating seizures and avoidance if possible, instruct to avoid excessive alcohol, fatigue, and loss of sleep, details of medication dosing, side effects, and importance of medication compliance, that they must take the medication exactly as they are directed and not miss doses. Stress the importance of laboratory monitoring tests with some drugs, and advice on living a healthy lifestyle and avoiding things that may trigger seizure activity, like sleep deprivation, increased stress, alcohol, and drug abuse, and counseling women of childbearing age about epilepsy, medications, and pregnancy. Oxygen and suctioning equipment should be readily available. A saline lock may be necessary. Place the bed in the lowest position, and again, never insert a padded tongue blade into a patient's mouth during a seizure. 4 side rails up are considered a restraint. Do not restrain a person's movement in any way except to prevent injury from a possible accident. Do not move any hard object between the teeth or in the mouth. The tongue cannot be swallowed. Do not attempt to give the person liquids during or the immediate conclusion of a seizure. Do not give artificial respiration or oxygen during a seizure. However, if normal breathing does not resume at the end of the seizure, artificial respirations then should be started. Do not shout at the person or expect a verbal response to a verbal command. A seizure dog is one that has been specially trained to live and work with people who have epilepsy. Some are trained to bark and alert the parents when a child is having a seizure outside or in another room. Some lie next to the person having a seizure to prevent injury, as seen in this demonstration. And some work has been done training dogs to warn before a seizure occurs. This gives the person time to lie down or move away from a dangerous place. No one really knows how dogs do it. The theories are that the dog picks up a change in scent or behavior and believe there are chemical changes going on in a person's body before an episode. There is no scientific proof except it works. It's just a natural instinct and one of the mysteries of dogs. Patient and family education. Anti-epileptic drugs may not be stopped even if seizures stop. Refer limited income patients to social services. All states prohibit discrimination against people who have epilepsy. Alternative employment may be needed. Vocational rehabilitation may be subsidized. Take medications as prescribed. Avoid alcohol as this lowers the seizure threshold. Avoid driving and no heavy machinery. The patient may be able to swim or go into a hot tub as long as they go with someone who knows that they have a history of seizures. They should never go swimming in a hot tub or in a bathtub by themselves. Monotherapy treatment is with a single agent, and that is the goal. Seizures can be controlled with one agent in approximately 75% of patients. Management becomes complicated when patients are given medications in combinations. This also risks increase the number and frequency of side effects, making it less likely that patient will take their medication appropriately. For medications to work effectively, a relatively constant level of medication must be maintained in the body. This is accomplished by taking medication regularly as directed without missing doses. The consequences of missed doses may be a single seizure, more devastating, multiple seizures, or status epilepticus. Divided doses may be preferable with some medications, ensuring a more constant level of medication in the bloodstream. Appropriate dosing levels depend on many factors, including the patient's body weight, concomitant medications, and reaction to treatment.